Hello, I'm Peter Leo. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University, Feinberg School of Medicine in Chicago, Illinois. I'm also the founding director of the Chicago Integrative Eczema Center. Thank you for having me. Our first question is, what do you feel are the biggest differences between adult and pediatric patients with eczema? Well, it turns out that I think overall, there are more similarities than differences, that adults and kids, from a conceptual framework standpoint, we really approach them very similarly. We start out with good education. We make sure we're removing things that are causing triggering factors or causing eczema flares or irritation or allergy. Then we can be reactive with our topicals. Then we can go to proactive therapy and so on. We can follow that same pattern. The biggest differences, I think, really are in the way that we manage it specifically. And that's because what an adult can easily do in terms of a cream or a lotion or a shot, for example, is much harder because little kids, especially babies, they can't do any of these things themselves. So we have to be much more cognizant about the potency of things that we're using, about the texture of things that we're doing, about the potential for tolerability issues. Stinging and burning is way more intense for little kids because sometimes if they have a bad experience, they might not want to put anything on their skin again. And we get stuck sometimes with these situations. So all of those pieces of the puzzle have to come in. And we're thinking about those things. But honest to goodness, by and large, the structural framework is very similar, and it really is just in those details. The other piece, of course, that is really tough is we have a third party. We have a parent who's involved. And that means we have to not only convince the patient and do a shared decision-making with the patient, depending on how old they are, that may or may not happen for littler kids, but we also have to involve the parent. And we have this little triangle that can be very tricky. Sometimes the patient is excited and the parents are saying no. Sometimes it's the opposite. The parents say, this is what we need to do, and the kid says no, and we have to navigate that. And that, I think, is why a lot of people don't love seeing kids. I love it. It's part of my practice, and it's something I really cherish, but I get it. I get why some adult dermatologists and some adult focused clinicians just say, yeah, that's okay. You guys can see the kids. It's sort of a circus sometimes. The next question is, what is the number one mistake you see clinicians make in treating their pediatric patients with eczema, and how can it be avoided or improved upon? I think that the hardest part with kids is that we either are too gentle and kind of too afraid to treat them appropriately, or we're too aggressive. And it's difficult to get that Goldilocks zone in between. So I see both of those extremes. I see people who are so nervous about putting any cortisone on the kids or using any medicines that they sort of undertreat and just say moisturize or wait, use the tincture of time, so to speak. And I have patients who come in who are very frustrated. They've been suffering for a long time, and they feel, and they are honestly, chronically undertreated. So that's one side of the story. The other side, of course, is people that are maybe a little too cavalier and will start kids on oral systemic steroids or putting them on super potent steroids when they maybe haven't really worked their way up to anything like that. And we see this sort of disconnect sometimes. They sort of feel like, kids are tough, they'll bounce back. And we want to be a little more careful sometimes. So it's a delicate thing to thread, but those are the biggest issues I see. And I also think that sometimes we have situations where the parents aren't really involved completely, where the parents are feeling that they're not being heard, that sort of they have to have a voice and they have to have a decision in this. So that shared decision making with a pediatric patient really is a triangle. We have to get the parents happy, the patient happy, and the clinician. We all have to be in alignment, and that is tricky. The next question is, what recommendations do you have for clinicians whose patients, parents, and/or caregivers would like to try more integrative approaches to treating their eczema? I think in general, part of the beauty of integrative approaches is that to some extent, we do them already. Most good dermatology clinicians use things that are off-label. We use things that are maybe approved in a different situation, in part because if you don't, you literally will have no tools in your toolbox. I mean, how many FDA-approved treatments are there for lichen planopilaris? None to my knowledge. So you have to think out of the box automatically. So we're kind of used to this. And I think what my recommendation would be to at least open your mind to it. If you're interested in it, there's lots of literature now. There's even a journal that I'm part of. We put together a journal called the Journal of Integrative Dermatology. It's really been fun to put that together and get editors and get people to help put out a journal that really is an area of focus that I think is sort of underrepresented out there. So there is some data out there, but there's also the experiences that we can have and the families have, and we can learn from them and talk about things. Part of our job, of course, though, is making sure that we're not doing this to the detriment of the patient. We have to be careful. We don't want to hurt them. We also don't want to hurt them indirectly, because we could say, well, this is a gentle treatment, but we're now delaying a more powerful treatment. So I often talk about these in integrative terms. We're going to do usually something from Western approach, the conventional or evidence-based medicine approach, and then we're also going to pair it with something perhaps gentler or more supportive. And I think when we do it that way, in general, the things that we're talking about are pretty safe and pretty gentle, and most families really appreciate it, even if they don't use it. Sometimes it's nice just to say, hey, listen, we can add on topical sunflower oil. This may be a useful booster in some ways for our own ceramides. It has a ceramide inducing effect endogenously. It also may have an anti-inflammatory component. Maybe we're going to bring coconut oil on board. There are different things that we can do. So I think that if you're interested, start reading about it, start asking. There are conferences that are devoted to this. There are journal articles, and then try it, because typically they're fairly safe things that we can do. And the things we're doing on a daily basis are orders of magnitude more serious. Writing a prescription for an immunosuppressant is many, many times more intense than having somebody try some coconut oil. That's not to say coconut oil is perfectly safe. People can have allergy. They can have a bad event. I'm never going to say that. That's patently false. We know there are problems with these things too, but it's not quite an apples to apples comparison sometimes. The next question is, do you have any particular pearls for combining more pharmacologic therapies and more natural interventions into a patient's treatment plan? Yes, there are many things that I do that I think are, if they're not synergistic in the truest sense, they're at least additive. We get a really nice balance and we get sort of a bonus effect by having them together. So for example, one of my favorite treatments is to use topical vitamin B12. We have this compounded for our patients. There actually are a couple of really, I think, convincing papers that it works. And my own experience is that it is very helpful as an anti-inflammatory, more as a preventative treatment. So people, they could use their topical steroid or non-steroidal prescription treatment to cool things down. But when they're better, they can switch to the topical vitamin B12 preparation. What's really neat is it seems to help lengthen that interval for a lot of patients between flare-ups. Now, it's pretty inexpensive. It's pretty darn safe. And most of the patients I've given it to really like it. The biggest problem with it, some patients say it didn't do much. They're like, well, that was kind of an expensive moisturizer. And it's not terribly expensive, but it's certainly more expensive than just a regular moisturizer. It's on the order of $25 or $30 for a tub. So not insane, not drug pricing, but still, it's a cost. And we have to be conscious of that, especially if we make a lot of recommendations. Other supplements that I really like, I have patients take some oral hemp seed oil. Now, this is not marijuana. This is not cannabinoids we're talking about here. We're talking about the food grade oil. And what's interesting is there was a beautiful study that showed patients who took, this was in adults though, adult patients who took 2 tablespoons of hemp seed oil per day actually did better on their eczema severity score and a number of measures. And I really think there's something to this. So these are a couple of the things that I've used, very, very safe and gentle. And I think patients really appreciate it. We have many, many more, of course, that we can dig into. And I don't want to bore you with all of that now, but those are a couple that I think are ones that I'll give one more. There's one more go-to that I like a lot that came about just a couple of years ago. There was a paper out of Germany showing that a black tea compress, so we're literally talking just plain old black tea, you'd brew it up. It's technically the second steeping. So the first cup you might drink or pitch that one and then do the same tea bag in the second steeping. It's a little milder, a little more dilute. Then I have my patients put it in the refrigerator, get it nice and cool, and then just take a soft cloth and do a compress. And what they found was that it made a dramatic improvement in facial eczema in just a couple of days. So fascinating. And I've been using that a lot in my practice. Again, very safe, very easily accessible and inexpensive. And it really does seem to have an effect. But I would ask, people to try it, see what they think. The next question, the 32nd Annual Masters of Pediatric Dermatology will return to Miami Beach in February 2024, where you will be giving lectures such as box warnings, how to address safety concerns, vehicles and patient adherence, and pearls for patient education. What can attendees who want to learn more about managing eczema in pediatric patients hope to gain from these sessions? Well, I'm very excited about the Masters of Pediatric Derm Conference. It's one of my favorites. It's a much more intimate, very clinical conference. We talk a lot of science and scientific data, of course, but I think it's really designed to be more practical for clinicians. And I always have a great time. I try to update everything to the minute. Sometimes I'm literally pulling in papers that I read the last week or even the day before. I say, this, I just saw this. This just came across my radar. So we're really trying to get people up to date. And then there's a wonderful practicality of it and then some questions and answers. So I think if people are interested in this stuff, please come join us at the meeting, experience these different speakers, learn about all these new ideas, some which will hopefully be novel and interesting and stimulating, and then hang out with us, talk to us, and we can actually engage engage and think about tough cases and tough situations and sort of the state of the art and how to balance all of the incredible changes that we're seeing in dermatology and medicine writ large right now. Thank you so much.